The mic is hot. The stories are real. Welcome to Dallas On Air.
Hi, my name is Brandis, and I'm with BIomazze Coordinator Chronicles, Healthcare from A to Z. Here today, I have a very special guest. Her name is Sheri Wallace. I would like to introduce you all to.
Hi, happy to be here. I am a physician office rep from AcariaHealth Specialty Pharmacy, and I do Arizona, Colorado, Utah, and Wyoming for my territories.
Oh, wow, you have a huge territory.
I have a giant territory.
She is one of the best pharmacy reps I've ever had to actually work with, which is speaks volumes because I've been doing this, of course, 24 years in the healthcare space, dealing with specialty medications and making sure our patients get the therapies that they actually need when our providers decide to write a medication. We want to kind of talk to you all about why we do this, just so you guys can hear a little bit about our perspective of things, and then we'll kind of talk about some of the challenges that we see and face today. And then we're also going to kind of discuss a little bit about that Medicare IRA plan that everybody's so afraid of.
Yeah.
So let's start with you. Why are you in the healthcare space, and what made you become such a great advocate?
I have always wanted to educate people, and fairness is a big thing to me. Just from being a little kid, my biggest complaint was it's not fair. And then I got into the women's health space, and at the same time I was dealing with psoriasis, but I didn't know what that was. And so I kept trying to figure out what it was. It would kind of flare, it would kind of go away, but it ends up that now I have a really, really severe case of psoriasis. But at the time, there weren't really great drugs for it. And so when the first drug that I was comfortable taking came out, I went to the dermatologist, and they were like, well, this is a great drug, but you can't get on it because it costs so much money. And I was like, no, there's a copay plan. And they're like, well, we don't know, that isn't going to work. I was like, no, I think it'll work. So it ended up that I was doing my own PAs, and I had taught the office how to do PAs.
Wow.
I taught the office how to do the copay assistance. I had called up the pharma company and said, my dermatologist doesn't know who you are, and why is this? And he was an older provider. He was trying to retire. His office staff had all been with him for a very long time. They weren't up on these kind of new things, but he was also training new physicians out of the university. And I told him, I said, you have to be more up on the newest drugs because people like me need these things. And I do have a really severe case, so I think that really helped spur them. But I was really researching all of this. The pharma rep would come in, I'd be talking to them. I realized they gave samples. I asked them how that worked. We had lunch and learns, and I was in there as part of the office trying to figure out how this all went, I mean, at the time I was working in med device, so it wasn't completely foreign. But then when this job for Acaria came about, it was after COVID, and I was looking for another role. And I thought, how hard could that be? Because I already write my PAs. I know how to do appeals. And I was just already fighting with the PBM for the insurance I had, and they had moved me back to Acaria after leaving, someone we don't like to talk about. And so I'd already fought that. And I said, hey, I should apply for this job. So then when I interviewed, that was one of the first things. They were like, why did you interview? And I told them. And then now it really is that when I go into offices, I feel, or when we talk to patients or people are hesitant to talk, or I don't know, there's just so many obstacles to getting people on the right therapy for them. The hard times, I always think that there could really be somebody like me who, at the time, I think I was really close to being suicidal because I was probably 70% covered with no treatment. I've been through so many topicals and so many things that if a biologic didn't work for me, I didn't know, honestly, how I would keep working, functioning. It gets to the point where you can't really go out in public because how much can you hide of yourself anymore?
Right.
So that's really now it's what keeps me going, but it's what got me into it was just the need. I always just think the person on the other end of the phone could be somebody like me who isn't going in public, who's covering things up. So many people with really bad psoriasis can't keep jobs.
Yeah.
Because like somebody was just telling me they were a server and they'd gotten fired because people didn't want to get food from them because their hands were so covered.
Oh, man.
That makes it really difficult because how do you support yourself to get the insurance that we're all fighting to make work for the patient, right? But if they can't stay on the insurance, and that's what makes me fight really hard for the at-risk customers. That's why I'm happy to have the job I have, because it's mostly Medicaid, Medicare focused. Like I always tell people, we don't do too many bougie insurances. We're really here for like the down and dirty stuff. But that's, and now because of access to 2 different biologics, I'm almost 100% clear for the first time in almost 30 years, maybe more.
That's a beautiful thing.
It's crazy. Like when I see myself getting out of the shower and I think, oh, now I have to put this on and then this on and I don't have to do it. I'm like, oh, that just shaved a half an hour back to my life. But it's a gift, like you don't take it for granted.
It's crazy because you being a patient having to implant yourself into your own doctor's office to write your own prior authorizations and to actually contact the pharmaceutical companies and the reps to get samples. A lot of our patients don't have that, and they don't have that access. No. So can you imagine what they were actually going through?
That's why when I yell at people on the phone, I would tell them, like, this is me calling to work through this, but imagine if I was cognitively impaired. Imagine if I couldn't take time off my job to spend the hours to call you. That's a time-intensive process that if I was working at many jobs, I wouldn't have during the day when you're only open 8 to 5. What if I was someone who just felt uncomfortable calling a medical place and didn't feel qualified or worthy enough to be calling to advocate for myself for one of many reasons? Imagine if I wasn't sure if my insurance would cover it. Or what if there's many parts of the process where the copay amount is there and you see what that might be, but you don't know if you're there's like the copay and then there's the debit cards and all the steps to it. And I feel like patients, especially Medicare patients now with all the levels of how that gets paid, they're giving up at the very first moment because they don't have faith that that's all going to work. So whenever I get really, really angry with people, that is what draws me to that line of being angry and just losing my temper on someone, is because imagine if this wasn't me.
Right.
Imagine if it was, and we have parents who are calling about their children.
Yeah.
I'm like, you imagine if this is a small child that's going through this. Like, you have the parent who's trying to care for them, but you have 2 patients really, or a whole family for some of these kids, and they're so sick, and their parents are so just challenged, emotionally, physically. They're not sleeping. Yeah. So that's really, I think, because I've been there, and I can always, and it doesn't take much to put yourself back in that trauma.
Right.
Right. So then you realize, like, that is what makes me angry. Most of the time I can be very professional and hold it back. But then once in a while I'm like, if this wasn't me calling to go through this with you, imagine somebody else, like how you should be doing so much more because you're not doing it for me. Imagine what some other people go through that you managed to just get dropped out of the process.
Yeah. I always tell myself I want to be a voice for those who don't have a voice or who don't know how to speak up for themselves. A lot of times when I talk to patients about their disease state, they don't understand it at all. And Dr. Google comes into place. And, I don't want patients having to Google things. I want to be a resource to them. I want to be able to make sure I'm advocating in that way, because I've noticed that the more resources I provide, the more likely they are to actually stay on their therapies. Do you kind of feel that way as well?
I think that's a really important point, because patients should, if they're on a monthly medication, be getting 13 fills a year. Average that I see, even when we're all working really hard, everyone in this, and it's going well for them. I don't have numbers, but it can be about 10, 11.
Yeah.
It's hard for people because even once you're approved and you're in the system, there's still so many barriers to getting you on time therapy. Getting that drug to your house before the next dose is due. And I feel like unless we're preparing them for what that looks like, for the number of persons that are going to call them, you know, I'm talking to patients or offices, new MAs, when I'm educating them about the process, a lot of them have never gotten a biologic, and then they're not the ones doing all the biologics at first because they're new to the office. So I'm explaining to them there's going to be, you know, make sure to tell your patients there's all of these steps, right? So they're going to leave today, the prescription's going to go somewhere. It may take 2 or 3 times to find the pharmacy that works best for them and their insurance, depending on what's going on. Those people are all going to call. 800 numbers are going to call you like you owe thousands of dollars, but you're going to have to be brave and pick up the phone because there's nurses. If there's REMS or other things involved, there's going to be more people calling you to talk about how you're feeling, any kind of side effects. Make sure that you're talking to your other doctors. This is a complicated process. At the specialty pharmacy level for those drugs, it's very complicated for patients.
And then also talking about those comorbidities that you were even talking about earlier, like with the suicide. A lot of patients don't even want to disclose that. They're too embarrassed to talk about those difficult things.
And one of the drugs I'm on has a black box warning, and so I get to see and fill out that paperwork. And as much as I'm removed from that currently in my treatment, it's not as raw. Sometimes when I sign those forms, it still makes me a little teary.
I bet it's one of my favorite medications too.
I'm very happy with it. I do have to take 2. But they're both very good. I just feel like my disease was so advanced by the time it was properly diagnosed. And by the time that I had all those comorbidities, that everything drives each other. But I'm hoping that with all of the new drugs that I am on, thank goodness for all of those, that I'm starting to see my inflammation levels go down for the first time since maybe I was in high school. That's
awesome. That's really, really awesome. And if I'm thinking of the medication that you're on, I think it's the black box warning only happened because of the way that the clinical trials were designed.
I don't know. That's what I've heard.
Okay.
But when people ask, that's one of the common things that we talk about in the office, because I don't go into the office to talk to the providers about what they're prescribing or talk to them about their clinical dosages. If they want the patient to be on 3 times the typical dose, that's not my talk.
That's not your niche. Yeah.
No, I want them to be able to have that discussion with the healthcare company for that patient.
Okay.
Because they're the prescriber. I'm the person who advocates for the patient and tries to get everything through in the middle between them and the patient.
Okay.
So when they talk to me about it, though, they'll say, and then a lot of my offices, we see the same people time after time, and they'll say, oh, how are you doing? And, you know, how is your clearance? And so several of them know what I'm on, and we've had discussions about it. And so they'll say things, and I'll say, when they ask about that particular talk about black box warnings and things like that, I said, you know, I am probably, 10 times less suicidal than I've ever been. The thing that drives, and I can only speak about my disease condition, which is the psoriasis, but when you're itching and you're hurting and you put stuff on, like I was once using some things and as topical, and one of them being magnesium oil that I was making myself, and you spray that on after the shower, and my husband was helping me, and he got it in a hangnail and was jumping around screaming. And I was like, babe, I got 80%. Imagine what that feels like.
Right.
You know, sometimes I just have to stop because the pain is so much. So when you're in those times, you really think, like, how much of this more could somebody take? So I tell them it's really, but I also think that people without black box warnings, we need to be checking in on them more as well.
Exactly.
Because we don't know what people are going through on a particular day. And you don't know how even diseases that are less seen but probably more likely to result in really embarrassing public, like gastro issues or something. You know, you don't know what that person's going through or how much they miss work because they can't trust that they're not going to have an embarrassing accident.
Right.
And I'm like, I think we should all be very open about mental health and asking people where they are and providing options and making sure that if you think your patients need extra services, as I work for a pharmacy that's owned by a healthcare company, and so I tell them I can help them refer them to someone at the healthcare plan who can provide them access to extra services if they need it.
Oh, that's awesome.
Rides to the doctor, all kinds of things if they're having trouble with the therapy that they're on in your office, but maybe also other challenges.
Right.
So the insurance generally is not the horrible guy, I think, that we think it is, or that we're dealing with a lot of the times. I think it's the process between them and the patient that we're all in. That's a horrible process for sure. But I think for the most part, they don't want patients to go to the hospital. It's more expensive. Patient care really suffers. Keeping people on the lowest therapy possible, which is the most healthy for them, isn't possible if we have people ping-ponging to the hospital and home.
Yeah.
So I think they do want to provide extra services. And I am also would say that I'm very happy when I see what Centene does for their patients, because we do offer a lot of extra things, that I see in action at the different plans. And so that makes me happy, because I think coming from women's health where nobody wants to pay for anything, there's so many mothers with new babies that just need food.
Yeah.
And that's where I came from before this. And so I think realizing the challenges for people can be very simple, but that's why you're not seeing them in the clinic, is because they don't have the money for the bus.
Right.
I mean, you don't.
Or even the visit.
They don't.
I hear it all the time. Like, I can't afford that $50 copay or that $75 copay every 6 months, 3 months.
That's why, as we talk about biosimilars and mandatory switching, I try to tell the offices in advance and say, look, we all know there's patients who can't afford the specialty copays to come in. And, so we know this is coming. Let's try to get those patients in and have that discussion about what you want to see have happen to them. What are the step therapy laws? What are the other things you can use if you don't want to switch this patient? If they're going to be switched, let's try to do it before it's like so abrupt. Work it in with their 6-month or 3-month visits or something. That's important. And then I think also with the M3P situation and patients being so challenged, one of the things I had to really add to every morning I do anti-racism privilege work just before I get out of bed and start the day from that perspective, because it will wear you down over the day.
Oh, yes, definitely.
And so just starting out with this, how am I going to make somebody else's life better today, even though there may be so many challenges to it. I had to add in elder care issues, because I had really thought that we'd have so many people on the M3P program, like lots of them. And then they're all telling me, and we're having conversations with them and trying to get them signed up, and they're like, I can't afford that. And I was thinking $170, $80 a month for a biologic that you couldn't get at all before. But they're like, no, I
still can't, because
they
they're on
still
fixed
can't.
incomes.
They're on a very fixed income. And so I didn't realize the depth of medication that they are foregoing because of patient decision. When I see that, I just feel bad in my stomach, and I think, man, because the therapies that they're being prescribed and declining to take because of that patient decision are not. I mean, we're not working with Tylenol, right?
Right.
And we're working with stuff that I think, man, that's really going to impact the quality of your life, the longevity of your life, your ability to do your life without additional issues. And so I think it's one of the big surprises, because I was expecting so many people to access that.
Well, I literally had a patient tell me that he would have to choose between medicine and groceries every month. And that's heartbreaking.
They tell us all the time.
Yeah, that's heartbreaking.
Yeah. And I was thinking, $170 a month is a lot for a biologic, because they're already paying for Medicare, obviously. But I was thinking that's more doable, and the quality of life advantages. And I was thinking, that's really privileged of me to think that I could spend that, because I could, And then I was thinking, but now it made me really paranoid about my own retirement. I'm really rethinking some things. I'm thinking, man, as I look at access to the drugs I'm currently on, I probably couldn't take those drugs if I was a Medicare patient.
I think I'm also shocked behind the patients who have to decline it, who also don't qualify for low-income subsidy. It is blowing my mind away, the rejection letters that patients are receiving. And I'm like, well, you're still below poverty. How is this possible? The poverty level was raised, and you're still barely making that. So something needs to be done, some type of reform.
Yes. And coming from women's health, pregnant women are one of the most difficult populations to work with in that area, because they're young. So a lot of them are in entry-level jobs because they're just, most people give birth before they're 30, let's say, and more of them at the younger end of that spectrum. So they don't have high-paying jobs. They may be in college. They may be working temporary jobs, whatever. So they end up in Medicaid, and people think, oh, Medicaid patients are, and they have a picture of what that is. And when you talk to people about what that person actually looks like in our country, that's most of your military.
Mm-hmm.
Your enlisted military for the first maybe E1 through 5 maybe qualifies for some type of Medicaid and food assistance like WIC.
Okay.
Many women of that age are having children who aren't married.
Mm-hmm.
And so they're not qualifying, they don't have resources at home. If it wasn't for their parents trying to add them to plans or doing other things because they don't have access to health care because, who can work after you've had a baby for 6 weeks? We all pretty commonly think that's not the case. But then they're not in a place to have that actually happen.
Mm-hmm.
And so the idea, I think, in our country of what people look like who are on Medicaid or look like who are in poverty needs to include teachers.
Oh, definitely.
A lot of healthcare workers, the people who you encounter so commonly, like, I don't know what this figure would be, but in Arizona and Colorado, where I am frequently, probably 80% of the people I come into contact with on a daily basis would qualify for some sort of aid.
Right. It's funny that you mentioned those states because I work a lot with Indiana, and I didn't know Indiana was a poor state until I started working with Indiana. And all of these Indiana plans, they all had like a Medicaid attached to them. And I'm like, how is this possible? Well, I didn't realize the poverty level there. And so these patients, at least they're able to get an additional aid that I see that other states are not providing to their.
Those are some really interesting plans. Arizona added one for families who make a little bit more money but need additional help with insuring their children and things. So it's it's a Medicaid add-on type plan, and it's for people who both work and make money, but they need help providing health care. So I think I don't know how many people are actually in that plan. I'd have to look, but it is interesting when they add things like that so that people can work and get additional health care payment options because it's not cheap to put kids through first, second, third grade at all, right?
No.
And how many kids in our country depend on school lunches,
right,
for healthy just eating?
I even saw something today that came out in an article about them. I think it's here in Texas where they're going to be paying or giving an additional $125 or something for those families who need to feed kids during the summertime.
During the summer, yes,
because they depend on those lunches to feed their children.
In my previous job, I was in WIC all the time, and those families depend on those SNAP benefits for food.
Yeah.
And they are constantly doing classes on how to stretch the budget of beans and rice. And now they can go to in most, I think all states now, but if not, it's the vast majority. But, it used to be the place where you'd have to go pick up at a warehouse the food and be in a line. It was very public that you were on SNAP and embarrassing. And you got cheese and potatoes and bread and things like that. But now you can buy what you want. But even then, the foods that are SNAP eligible, there's some discussion about that. What if you don't have access? Like we said, you can't afford to ride the bus to go to a farmer's market and buy fresh vegetables. So farmers markets are increasingly trying to work with SNAP beneficiaries to provide food.
Okay.
But, this is multi-steps for every challenge that these patients face.
Yeah,
and it seems like a lot.
It could become a headache, and you can see why some patients will fall off and throw their hands in the air and just say, "Hey, I give up," because there's so many additional steps in place.
Well, and there's so many people needed to get some of these patients to their appointments.
Yeah.
I was in an office the other day, and someone was driving a patient, and they had some issues, so the patient was 45 minutes late and needed rescheduled, and they were in the car waiting, and so she came out to tell the person we had to reschedule, and he was like, but I'm not the one that was late, you were late. And she's like, I understand, but I'm just the person who drives you, and this is a situation. And he just started crying. And I just felt so bad, because she didn't do anything wrong. This driver wasn't, malfeasant in any way. I think it's probably, you and I both know being in the doctor's office is not a scheduled situation. It takes a long time sometimes to get in and out. So her previous person could have put her behind. But, this patient now was going to have to come back And he was like, well, I had to have help with my caregiver this morning. And she's like, it's okay. She was very kind. She's like, we'll work it all out. But I was just thinking the steps needed for that person to get to the front door in that handicap spot this morning, to have to go home. And how long has he been in the car?
Yeah. I have a provider that I used to work with who didn't believe in like turning away people even when they were late. We would see you an hour late. I mean, the staff wasn't always happy, but you have to take into consideration, have a little bit of empathy about what just went on.
I mean, I agree.
Yeah.
I have thoughts when I'm standing there, but
Yeah.
you know, at the same time, I'm like, okay, one person make their life better right now and just keep moving, you know, because in my job, there's no thoughts that I can have that I can say anything about. But
Yeah.
but I also think, you know, it's one of the significant challenges in the space right now is that offices are packed. They're busy. Medicaid, Medicare accepting providers are busy. And
They're far and in between.
there's not a lot of them. And they're challenged to see all the patients. Arizona keeps adding people moving there. Colorado, same. The population is growing. I'm not sure how many people are choosing healthcare like they used to as a profession. And I'm just seeing offices be very challenged in how they provide healthcare to their patients across the board in all the specialties. I've never, and women's health, nobody pays. So I don't come from a place where I think, oh, everybody just gets access to things. I realistically know the battles that people face just to get food or bottles or a breast pump or whatever it is, right? But I think now it's exponentially worse in offices.
So it's interesting that you brought that up because I kind of want to talk about some of the challenges that we actually do face in the clinic, out of the clinic, even on the pharmacy side. And I know with me, it depends on what specialty you're talking about because I work in multiple specialties. As you may know, I'm in dermatology, I'm in asthma, allergy, immunology, and then I touch a little bit into the rheumatology space. And in dermatology, I see a lot of times it's documentation, it's our providers, and in derm, you all, it's almost like a sweatshop. And I mean it. It's like a revolving door. Medical assistants are doing all of the documentation, everything that the patient may need, and the provider's literally in the room 5 minutes. And you get this huge bill for $300-$400 after that. And then he goes on or she goes on to see the next patient. And sometimes they're seeing 80, 90 patients a day. And I feel like we're not capturing everything we need in the visit in order to get a patient on a specialty medication. And I don't know if you're seeing some of that too on your end, but I mean, documentation is terrible these days.
I see a lot of those challenges. And when I'm in the office, instead of talking about like the clinical things like a pharma rep would, one of the main challenges is to talk about what I'm seeing with the claims that are coming through with the prescriptions and to say, hey, and it's obvious when I walk in and I see new faces, then I know their challenges that they've gotten new MAs. But consistently also providers may not be documenting as much as they would like. And you and I both know that in a clinic where there's, say, 10 providers, there's always one provider who's like, I want the notes clean. I want the notes short. I want the notes like this. And so their charting ideas are not. And so then I try to gently say, look, we have MIPS, which is a big thing for you, and your office managers are talking about this. So it helps your MIPS. It helps your approval rates. It helps the people who are getting those approvals if when you're in the room, you do all of the things, and I know it's a lot, but if there is never too much documentation. Never. And so what you think is adequate is probably far from adequate if this patient goes into a further appeals process. So, I mean, we have patients all the time who've changed insurance 3 or 4 times now. This season has been crazy, but I have a patient that somebody was just trying to push through quickly. It's their 5th insurance.
Oh, I have several patients like
as
that.
we go through redetermination, they keep dropping off of Medicaid onto the marketplace, onto Medicaid, and it's not always like they drop them back and forth in the same healthcare family. So the patient has been on several PBM directed situations. And then they're like, well, how come I need a PA? Because this patient has Medicaid. I was like, the patient doesn't have Medicaid anymore. They have this commercial plan. And even though the patient's been receiving therapy and is showing progress, the progress from plan to plan is different as well.
Yep, it all goes down to scoring tools.
Yes.
And I try to teach, like, even when I'm speaking to offices and doing slide decks, talking, for different pharmaceutical companies, I try to go over as many scoring tools as possible and really push and advocate and saying, hey, it's best to put multiple scoring tools in your chart because you never know what insurance plan might want a different scoring tool.
Well, and as we see changes to medication access, formulary changes, often patients have comorbidities. Mm-hmm. And if you feel strongly as a provider that you want your patient to receive this and your office is struggling for that approval, but they have a gastro indication or the derm indication is for a higher dose or whatever you're trying to do there, the couple of offices need to see that patient, but they all need those notes.
Yeah.
And nobody reads your mind. So maybe if you think it's staying in your office, and this is where I really feel like two things. One, I've never seen offices so beat down under the pile of paperwork. Mm-hmm. And I think now it's normalized. The patients won't get what the provider wants them to have. Providers talk to me and they're like, how bad is it going to be? It's not how long is it going to be for my patient to get this and how can we make that process faster? Mm-hmm. It's how bad is it going to be and should we just accept something else because my office doesn't have the resources for this, because the physician's office is struggling to pay for the approval processes.
Well, it's crazy because I had to actually change the way I think and the way I say things, because I used to always just say, hey, if your patient's commercially insured, they'll always get access to the medication either by bridge, which is non-covered therapy, or by covered therapy on the formulary plan. Well, now I've noticed some of these high dollar plans that are on the market that will go through and say no PA needed. I mean, even the wildest drug that I know will need a prior authorization because it's not on anyone's formulary, it will go through, no PA. And then you go to submit it to the pharmacy, and that copay card's already maxed out with one fill. And I'm like, oh my God, the patient will not have access to therapy. And it's too late. I can't get them on bridge because there's no PA needed. Like, how do you even navigate that?
And I think that's the problem that we're seeing, right? Is that and so what do? You're just going to sample that patient. This is happening in February, and we're going to be expected to sample that patient for the rest of the year. Mm-hmm. And offices, doctors are angry. I always tell them, talk to your pharma partners about what the path for this drug is. Mm-hmm. That when it comes in, and I think now, especially in my territories, people are a little Wild West, and they do speak up, and they do say things like, "Hey, I was at a conference and somebody spoke up and said, this sounds wonderful, but what's the path to my patients receiving this unless they're on certain insurances?" There was a candid discussion in the room with the pharma manufacturer about that. Mm-hmm. But I also just think that offices are increasingly thinking, we'll just move everybody to AI PAs. I mean, I'm hearing that a lot. Mm-hmm. And I mean, on some level, sure, that may work for some of the lower level drugs that we're getting approvals for, because maybe we just need to stamp something simple. But then those patients that do get denied, you and I both know that the phone tree of AI does not answer phone calls from patients with complicated situations. There's just that denial on there. And then I just don't think that we're in a place. There are some good AI tools, and I do use them often just to look for studies or other things, because there's things coming out all the time.
Right.
So if I'm doing an LMN that's difficult, I will go look, absolutely, and find all the studies and use it. But if you don't have a person who cares about that patient and has access to the provider in the same office, I don't know any of the offices who have switched to those AI miracle situations who are really happy now. Mm-hmm. And I still visit them because I have plans that are not that easy to just send to the AI dream god in the sky. So I'm still seeing patients come through. Yes, their PAs may be done or not done, but I'm still seeing, because they submit a PA and it comes to me, I'm still seeing the PA denial amounts. And some of those numbers are staggering at how many PAs are written and then denied.
Well, and I even had to explain, just because AI is doing it, you have to think about it. If a human is getting it denied, AI is also going to get it denied. It's going to run into the same problem. Either it's going to come down to documentation, or you're going to run into these accumulators or maximizer plans, or plans that are maxing out copay cards or saying no PA needed. AI is getting the same result I'm getting. So why?
Or less.
Or less. That's very true.
What's their approval what's their approval percentage? That I want to know. And then let's sort that by drug and plan. And then let's talk about the people that everybody spends the most of their time on, because we can break drugs and conditions and things out and look at those people. AI isn't getting approval for those. And then if you're in an office that does procedures, what about getting the correct thing approved? Because, you know, that patient may be having the procedure at a hospital. So is that an outpatient clinic? Is it in hospital? I mean, there's a million ways to cut that J code, and people are not. AI is just writing something up, and if something's approved, they're trying to send that patient over, and somebody's looking at that and thinking this isn't going to work, right? And site of care changes are now just rolling in like the new thunder from the deep. We got through blizzard season, and now site of care. So not so much in derm, but in other areas, you know, we're seeing like, so infusion patients are just, they're bumping them around and around.
I'm dealing with a lot of that right now.
It's a serious consideration. And so I have a lot of offices working with us for home infusion for their patients, but then maybe the patient doesn't qualify for that, or there's some other issue, or if they're trying to send it through medical instead of pharmacy, or, you know, there's all these things, and the poor patients don't understand. I rode the elevator yesterday to a meeting, maybe Thursday. And this woman was telling me in the elevator about everywhere she'd been for an infusion that week who hadn't been able to service her. Because even though she's getting she was angry with her doctor's office. And I said to her, every single place you've gone, you've had an approval for, correct? She's like, yes, but my doctor should know. I said, no, your doctor only knows what's been approved. And it's when you get there that this facility, for whatever reason, isn't taking you as a patient. And you and I don't have all this paperwork to go through in the elevator to determine who's doing this, but you've been turned away at so many of the usual places that something else is going on. And it's probably not your doctor's fault that this is happening. The fact that you keep getting sent to places means they're working for you, right? And so she came in, and this place was, you know, so as I left, the infusion was on the other side of the elevator, and she was sitting in there, you know, reading her little magazine. I was like, see, you got it. And, you know, she was celebrating, and I was like, you know, she's like, I just hope I can come next month. They're not sure if I can come next month. And I'm thinking that this lady is not, you know, it's not once every 10,000 or 20,000 people. This is happening a lot.
It is happening a lot.
And I'm seeing infusion centers go up and down because of it, but also other access to, you know, care for site of care patients. And I really worry because a lot of times we're looking at kids.
What do you think about when the infusion center, the pharmacy, the PBM, everybody's under one umbrella?
I have no comment on that, especially like that's such a controversial topic, but I don't see that what my question always goes back to, how does that actually help patients?
And I want to know the same. And because I get notices saying, you know, this might change, or this might change, or this patient might have to go here or go there. And then my patients are like, well, now where do I go? What do I do? And I'm like, I'm sorry. Like, I don't know where else to send you.
The biggest problem that we have right now is that there are so many institutional structural blockages to therapy or medical care at all for patients because of the way that the system has been put together that, I mean, ask anyone to explain how a PBM works. That's a very long conversation.
It's very long.
Right? And so I think that's a thing. I think also just everyone siloing things and not talking to each other, you know. Even in my own family, when we silo things, that doesn't work. You know, we were just having a family discussion last night about who was supposed to get groceries, and I'm not even there. It's my 4th week on the road. But somebody raised the complaint that there was no groceries of a certain type in the refrigerator, and I was like, who is the person responsible for this? So that person got called into the family chat, and they were like, but, see, my job includes these silos and not this silo, and it always ends up it's my fault because you're the one on the road. I am the weak link, right? I'm not there doing my job. And they're like, if someone was here who had better skills at looking at finding, they would have noticed that we didn't have these key foods in the fridge and said something. And with a reminder, I would have completely done my job. And I feel like that's really where we are in healthcare. You know, you call somebody and they're like, well, you know, that's someone else had to do something for that to happen. Like, how many of those conversations do you have a week where you're like, that's not my problem?
Well, it's funny that you say that, because even though you have a PBM, okay, so you have a PBM in place, that PBM, even though you get an approval through that PBM, if you have a third-party plan like a maximizer plan, you know you still have to get an approval through the maximizer plan.
Well, and what's the keywords at the bottom of every authorization? This is not binding. There's some 6-word phrase at the bottom, like, this is not binding. We aren't promising. This is not a promise of payment.
Yeah.
And I think especially with patients who are dual, or like I have a lot of patients in Arizona and Colorado both who have some version of Medicaid and Medicare together.
Okay.
And so who pays for what and how those approvals
who's primary,
have to happen.
who's secondary.
Yes. And I will say that, like, those patients usually clear my desk in that 10 to 14 day window that I like to see, and we're very good at those for the most part, because that's the primary patient that we're dealing with is a Medicaid, Medicare patient, so we're very focused on them. But I do see other ones where maybe they're in 2 different houses. And so that makes it a lot more complicated. And so I help many offices where maybe I'm one of the houses and another big insurer is another house, and I'll say, hey, send it over there. And we are very blessed at Acaria too that we have access to the plans, where we can go to someone internally and say, hey, we're having this problem, and they can contact the plan. And a lot of time, like in Arizona, we had a mandatory formulary change on Medicaid, and the plan was so kind as to say, you don't need new PAs. Why would we need a new PA, right? This is no problem. So we'd contacted them, and they switched the PA in the background. So the office did not have to do that kind of work. And this is where our PEMs really do shine.
Yes.
And if you don't know your PEM and you're with Acaria, really try to get to know them, because as reps, we're in the field and we're doing the best we can, but we can't do all the hard work. Literally, we may seem like we're doing it, and we may take some credit. I do too. Sometimes, like, I'm like, oh, we did all this for you. But the we means me and my PEM. So my PEM's name is Sylvia, and I think you work with Nicole and Katie. And I mean, Nicole is she was my PEM earlier, and she moved mountains for me, and Sylvia moves mountains.
She moves more than mountains, let me tell you. And she can even contest to this, because everywhere I go now, I'm not downing any other pharmacy, but you all have provided some of the best services that I have ever seen across the board.
I'm happy to hear
when
that.
It comes to communication, when it comes to even explaining the MP3 or M3P, whatever you want to call it, the IRA plan to patients. Nicole will give you an entire breakdown, like, hey, I got in touch with, let's just say the patient's name is Jim Jones. I got in touch with Jim Jones today, and this is what we discussed, and they're going to enroll into the MP3. Their first shipment's going to come out on this date. Like, I have everything, and then I take that correspondence and email, and I attach it to the patient's chart to say, hey, this has been very well taken care of. And I love that. So everywhere I go now, I always ask people, have you talked to your Acaria rep? Do you know your inside person? And when they don't, I do a chain email with Nicole in it, and Nicole will find out whoever is in that territory for them and get them in contact. And
Nicole has been with us for a very long time, and Nicole is amazing. Absolutely. I mean, she knows a lot. And Sylvia's dealt with people this week that were really difficult to deal with too, like just complicated things where we had to fill out tickets and there's just silly stuff. Like, we had a patient who was rejecting for no PA, and there was PAs abounding because they kept saying no PA, so the office was just routinely doing more PAs. So I think this patient had a stack of PAs flying out of fax machines, but no one was doing the little stuff. And I do think that's one thing where we really shine, is that no matter who you are in the country, you have an Acaria rep. That person has a boss. So if you're not happy, you my boss's name is Phil, and he's lovely, but you call Phil. Phil can tell you who's supposed to be taking your office's incoming situation. Okay. And that person is attached to this PEM, like Nicole. So no matter who you are, you have access to that. And we really shine with those, because the majority of the work is going to go through like normal, right? But when you need to really talk to us, you don't have to call the 800 number. You can text me, you can text Nicole, whoever the situation is, and we will resolve it. And if it's really something more difficult, we even have, and we're clear to go to our bosses anytime and say, hey, we need help with this. And then they will really advocate at a higher level with, all the internal things between the plan. There's some walls between the plan and ourselves, obviously, at the pharmacy level, but we can send messages and work on things that I see having no chance of success in other specialty pharmacy organizations. And I think because we're smaller, we do have other challenges. Like, we're just now getting the fancy portal. But you'll be thrilled when Nicole can add all that right into, if you want to sign up with us for that, then we'll integrate with your ModVed.
And one of my
offices
all of that
would go right in.
One of my offices just did.
That's going to be great.
Katie had went by and got them all set up on everything.
Yep.
So,
and then the portal, you can see, and they can see that it's different statuses for the patients now, and you can chat with your team right in the portal. So that's really nice. You can say, hey, I see this patient's status is unknown. Like, what does that mean? It should say something besides unknown, so you know that's some kind of problem. But then also we'll be able to integrate and pull stuff out of your, if you want, and this is entirely voluntary on your part, but I have some offices testing now where we can go into their ModMed, pull the stuff out that we need to do the approvals, and then add things back in. And so that will all be in the chart for you.
yeah, there's a couple of other SPs that have been doing that. So
and we're just,
I don't
we're
see
new
why they
to
wouldn't.
it. No, people are,
Yeah.
people are really
Yeah.
asking for it because I think it's one of the big, it's one of the things that we haven't had access to because we're newer. Not newer, we're smaller. You know, there's not that many of us reps. We're a smaller specialty pharmacy, and there's some big giants out there. But I'm really proud of the people who've explained to leadership that this was such a needed thing. And I think it's going to make the coordination so much better. And as a goal, I think that, you know, us in the specialty pharmacy industry are always really trying to keep coordinators like you, especially at the level that you're at with your team and being so high. I mean, you have what, like 100% approval for some things?
Yeah.
Yeah. So, I mean, but that makes everybody's job easier, right?
Yes,
So when when it's superstar working to superstar, because that's who we are today, we'll just put us there. It makes things go so much smoother, and we have so much less problem. We just have less error. And I see, you know, that's one of the things that I do see with offices who struggle getting a coordinator to stay, or even realizing that they need to get a coordinator and really, that person's special. You know, they need treated, they need like care, they need shelter from, you know, like sometimes I was in one office and the coordinator used to sit in the bullpen. So everybody could walk into the office and just have at her. And I was like, why are you doing this? Like, and she's like, well, this is mandated. And I was like, how can you work like this? And she's like, well, I have headphones and I have things, but they're, you know, and now I think some things happened and she was able to advocate, and now she can work from home, which allows, they probably get 10 times the amount of work from that person when there's not a pharma rep, you know, on the back of their shoulder or something. But I think if this is going to continue to work, we have to work as a team. Especially pharmacy has to work with coordination teams and patient advocate teams.
Yes.
You know, in other specialties like oncology, they do have like special patient navigators and other people that enter the system because of the complexity of those drugs. And I'm seeing like with neuro, it usually runs through some sort of organization and they have people. But now they're challenged with site of care issues. And so their coordination teams are being stretched. I was just at a show for a neuro condition. They were telling me their nurse navigators are now going to have to learn to do PAs.
Oh, wow. That's interesting.
Sobering, isn't it?
It is. Yeah, that's interesting.
And think of the complexity of those PAs and the nurse navigators. It's not like they're doing nothing already.
Right. They have
You know,
many
we're all
hats.
stretched thin.
Yeah.
So I feel like we're at a breaking point where things are just not, you know, you got the flat tire on your bike. How long is it going to go?
I think all of us coming together cohesively as a community is what we need to do, and not look at it as, oh, this person's competing with me for this or that, because we're all here to advocate, right? And that's
There's no competition in this space, like
None.
literally none. Like as much, if you think that people are competing with you, who was it? I was just, I was at this conference and there was a guy doing digital caricatures of people. And he was telling me, because you have to sit for a minute and get this done. And I mean, you know me, I like to talk to anybody. And this is a fascinating job. How did you get into digital caricatures? Like, what was your life history? And he was telling me that at first when people would move to Arizona for this and start a digital caricature company, he'd think, oh, you know, I'm fearing competition. And he said now he wishes maybe 5 times the number of people would move because he's turning down jobs all the time. And he said it's just one of those things that the more you pull back from the situation and see the scale of it, you realize that competition isn't a thing. But when you're narrowly focused, it is easy to be insecure or worried or think there's more competition. But he said he could book himself probably 5 to 7 times completely, 100%. 5 to 7 of him could be busy all the time. And I said, like, how do you get that out? Do you go to schools and talk about this as a possible profession? Because it's such a cool job, right? Like I could see somebody who's an art person, not even knowing this job existed. And he was like, oh, I should try that. And I said, you should really try to go and talk about your job more, because he was making good money. He was happy. He's having a good time. Like, and I didn't know that was a job. I didn't even know there was such a thing. Like, literally, it was just at the booth, and they were awesome caricatures. But, you know, it makes you think in our profession too. And I mean, I'm older, so I've been through a lot of incarnations.
Just wiser.
Wiser too. But I've been through a lot of incarnations, and back in the day, there was other things like coordinators, advocates, and they had to struggle to get licensure and clinical pay for additional clinical things they were doing with patients beyond the usual, right? And there was a lot of competition in there. And now the need for so many levels of that particular type of person has exploded. There's probably still competition because, you know, we're humans and we're tribal and we compete, and we have our own Olympics in weird ways. But I mean, there's probably still competition, but there is no need for it, because those jobs are on the job board. Every time I go look at what I used to do and see how many people are being hired, I see 5 or 10 jobs at every major hospital, birthing hospital. There's just so many of those jobs out there.
Not enough healthcare.
Not enough healthcare workers. And that's what I think when you're looking around at the overcrowding in offices and the challenges of providers seeing their patients and the time that they have in a day and all that. I'm just thinking, it feels to me like I'm seeing less doctors coming, you know, than for sure in times past.
Well, and I've also noticed that, like, when they sell to like a bigger group, they want them to see so many, like they have to hit certain goals, and that's even hard on the staff. It's hard on the providers as well, because I've heard healthcare providers complain about that, you know, being part of bigger groups, saying, hey, I have to hit my mark. I don't have time. I can't talk to you. It's
always sobering to me to go in the lunchroom and see goals, because my parents were both medical professionals and I never used to see those, you know, and then I think, oh, nowadays we all work for corporate. We're all just a little cog in the machine, you know. And I had dinner with somebody who was venting that they weren't being supported by their physician that they had been with for many, many years. And she was telling me, she's like, the physician said he can't advocate for me because he's also just an employee just like me. And he fears that if he advocates for me too hard, his job's also in jeopardy. Like, in some ways, I guess we've become more equal, and there's less, you know, doctor here, nurse down here, and those typical gender roles and all that. I think some of that's gone away. But in the same time, how much has really helped? There's probably some office manager who, you know, is really the person controlling everyone's life in that particular clinic.
That's even if they have control.
Right. Some HR professional is writing, you know, I just call it the men in suits talking to the men in suits. That's what I call those meetings, because a lot of times there was just in women's health especially, I found it really disconcerting that so many of those meetings were with men in suits talking about women who had just birthed babies. I'm like, what do you know about this topic?
Did you have a baby?
Do you even know what's involved? Can we even talk about the body parts, frankly, without being, you know, nervous to talk about what we're actually, you know, discussing? I mean, we're talking medical devices, so we should be comfortable, but we're not. So why can't we get some people in here who are? And that's one of the reasons I did apply to work at Centene here, is that they were one of the first healthcare plans that I ever pitched to sell medical devices, who sent all women who just had babies to check the device out, being a breast pump, and question me, and then tell their, you know, leadership what they actually thought of that, because they were all people who used it. Okay. And I was like, oh, and we were all sitting outside waiting to go in. And when everyone in the medical device bidding room heard what was happening, and that they all had to go in and pitch to new mothers, and, you know, you could see we could see through the glass, there's different sizes, ages, everything. They were like, are they going to want to use it? And I'm like, typically we use it. Like, you know, there's always people nursing who want to see what it is, and we're happy to demo. So yeah, I mean, I commonly do that. And they were like, oh, I don't know. And I was like, well, you don't have to bid.
Well, you have been so knowledgeable. Can you tell the audience where they can find you? Is it September when you're going to be speaking?
Oh, yes. So I'm speaking at Healthcare Advocates September, the first week. So I think it's like the 2nd through the 6th, something like that. And I'm on the round table talking about M3P. So I'm really geeked about that, because the other people on that panel are bound to be fire.
Oh, yeah. And Is Melissa on that panel?
Yes.
Oh, yeah. It's going to be fire.
And I think there's also some policy people that it's going to be really great to see what they think about, because in September we know our patients are all going in to re-up their plan starting in October, right? So I think we should be full court pressing them with information, access to phone numbers that they can get signed up. I think a common misperception is that, this is all prescription drugs. So they think it's just their biologic.
Right.
And if they're doing this with me with their biologic, they're not going to get their Eliquis at Walgreens. It's like, no, everything's under that
covered.
Same $2,000 out of pocket. And so I think just signs, posters, I've been trying to think of something that we could put up in offices that says, look, did you know this is here? Can you call? Can you talk? When you go talk to your broker for the year about what plan you're buying, ask them how you sign up for this. Get the information. Have them help you sign up. I mean, you're buying the insurance. There's a number to call. They can be with you on the phone, or if you have a language barrier or whatever it is. But that's one of the challenges, that we can't directly sign them up, and neither can you. They have to work with their Medicare plan.
And also informing them to make sure it's on formulary, their medication that they're taking, because that also plays a big role.
Yeah.
And that $2,000 cap.
Right, and not all the brokers that they're going to even if they're really truly brokers. That's another discussion. But I think getting them to know what to ask those people, and then to maybe, like I've told the providers, look, if you see that the medication you're wanting is, you have Emma, open it up, run your medication list, look at the insurance list on the other little column, and say, if all of my patients receiving this have certain types of insurance, share that with your patients. Say, look, I'm seeing higher approval rates for this drug with this type of insurance. You might want to look into that. And then share with them how to look into that, because it's all, CMS has that all online.
They do.
And so I have lists and URLs for them, and they've been using them. I think that's been a big education. That's my most popular educational lunch when people ask for that, is to talk about the M3P.
Well, I would actually love to try to even have you come out in one of my offices and do that sometime.
Yeah.
Yeah, I think that would be a great...
And I can email you the stuff that I use too, because I think just you can have it, and then it's not hard to give patients an email with that link to say, hey, and the M3P will walk you through what you need from the very beginning, like the CMS site. There's an M3P kind of hub, and it will walk patients through, like, is this a good idea for you? Here's how this is going to work. Because what we don't want is people getting all kinds of bills for like $10 a month or something. Right. And we have to be smart and get them on the biologic first, if they also have an Eliquis. But I know there's offices where there's people doing that $100-some a month for Eliquis who aren't getting access to a biologic because of how that copay or out-of-pocket got structured.
Yeah. The
combination of those two with their retail and specialty medications.
Better education.
Hopefully.
Yeah. Well, I appreciate you, Sheri,
I appreciate you
coming to Dallas and sitting with me. This was amazing. And again, you all can find her at the Healthcare Advocate Summit in September. And again, my name is Brandis with BIomazze Coordinator Chronicles, Healthcare from A to Z. Thank you.
We're good.
Yes.